All right, good morning, and welcome to the Palliative Care Friday Chalk Talks. This morning's topic is relevant to everyone in our field. We've got the subject of diversity within our teams, not only to reflect the population that it serves, but also to improve the strength of the team itself. And so we're grateful to CAPC for connecting us with our guest speaker today, Dr. Sharika Newman. She's the Director of Palliative Medicine and Fellowship at Haven Hospice, has practiced palliative medicine since 2009. And a fun fact is that she's a grandmother of 6. So welcome, Dr. Newman.
Thank you, Marty. Thanks for that introduction. I am very happy to be here to have a conversation about diversity. We do a lot with health equity and CAPC, and this just speaks to our health equity initiative with CAPC. First, I wanted to start off with a question that capitalizes on everything we're talking about today. And does the diversity of your staff reflect the diversity of the community it serves? And I can tell you that most of the times this question is no. When we did community needs assessments in the past, we saw that the staffing did not reflect the community it's serving. And it was a very awakening moment for most of the palliative care teams to even see the type of community that they serve. I think one of the biggest things that we sometimes are reluctant to talk about is racism in medicine. And racism is trauma. And I think sometimes it's present when we are unaware. So recently, this video went viral where Dr. Ravel found that pulse oxes were more likely to read lower incorrectly in melanated skin or Black skin compared to others. So someone with a reading of 90 or 92 could actually be in their 80s with a pulse ox. And it was surprising to me because I had never really thought about that. We think about it with nail polish a lot, right? Like when someone has on dark nail polish, we always put the pulse ox somewhere else. But we did not extrapolate that possibility out to dark skin. And now we have something that was not even known or that we weren't practicing in the face of being racist or biased, but we all were doing it. And so it's very prevalent in medicine. And I think sometimes it extrapolates out to our teams when we are not serving, or at least have people on our teams that look like the population that we're serving. We can create a institutional or team bias unknowingly. So we all know that there is a workforce shortage of like projected to be 18,000 physicians based on what we optimally need for specialists. I think the last time we calculated was like one provider for every 1,200 patients. That was a shortage for our palliative care team. And we only have 250 fellowship trained physicians entering into the field every year based on the programs through ACGME. Plus there's a cap on how much GME funding there is coming out of Medicare. And so a lot of programs have to rely on grant funding and things like that to be sustainable, which of course can ebb and flow with economics. So recently the economy hasn't been good. And so philanthropy hasn't been good across the board. And then we see shortages very similar to this in all of our disciplines. I know for me, where I'm currently working, the ER is completely backed up. And it's not because we don't have beds upstairs, it's because we don't have nurses upstairs to service the beds. So it's a shortage across the field. I really think COVID exposed things in our field that were already weak and made them a bigger gap. Nurses began to see that they can go other places and get paid more money for the same amount of risk with less drama and trauma, right? And people realize I could live on less money and still be happy. So I think people decided and made different decisions for themselves, which has worsened this workforce shortage. And then because there's a workforce shortage, it just lends credence to an already prevalent problem or problem that was already there and made it more prevalent. And that's a lack of diversity in medicine, a lack of diversity on our teams. And barriers to the use of palliative care by racial and ethnic minorities include the absence of this minority on the staff. I can tell you that in medicine, most of the time, I'm present in rooms where I am the only melanated person in the room. And that just is how it is. It's unfortunate, but it needs to be changed so that patients that look like me are comfortable having dialogues with the medical staff. Exposure. Institutions with the highest Black enrollment offer fewer opportunities for both their residents to learn about palliative care. And that's sad. Fewer opportunities for their physicians to obtain specialty within the hospice and palliative medicine. So if you look at HBCUs and other institutions where there's a high Black population, there's not a matching exposure for that Black population to become, to advance in this field, to advance in medicine. So then we don't have Black physicians, Black nurses, net chaplains to select from to be a part of our team, because there is a problem at the institutional training level. So we wanted to kind of, give you the hard, ugly facts and open it up for discussion. Brittany is on the line. She's quiet and not presenting, but present. And she is over the health equity portion of CAPC. And so some of the things that we wanted to discuss is how have you worked towards equity, diversity, inclusion within your palliative care teams or your organization at large? How have you guys done that? We just have a few questions that we want to pose to the group and open up for discussion in chat. And Marty, I don't know if you guys normally have everyone come off of mute. People can, for me, you can just jump in and.
Yeah, absolutely. I'll start to give people sort of a moment to think and simmer. As a team, we've been talking about this a lot lately. And I maybe this doesn't quite exactly answer your question, but I wanted to tell you about someone on our team and how important they are to us and how much we recognize how important this is. And also comment on your statement about comfort, people talking to people similar to them. So I'm going to put her on the spot. So I'm going to tell you about Dr. Pooja Bhatt. And she is the most outstanding clinician on our team. And it's not just because she's brilliant. It's because she makes us stronger because of the diversity that she adds to our team. And so she speaks a multitude of languages, and that allows her to really share with us some insights into how imperfect our process is about using medical interpreters and some of our blind spots. She has practiced medicine in many different countries, and so she helps us appreciate balances of autonomy and community and paternalism and end of life and family dynamics that we just didn't even know that we didn't know. And about comfort, frankly, some families are just more comfortable with her because she looks like them. And we struggled a lot over the last year as what should we do with that? Should we be trying, or should we lean into some of those things? And sometimes that's a strength, just having people that look, it is a strength, having people that look like your patients, and it's okay to use that on your team. That's just what I wanted to say, my 2 cents.
I also think it's vital, Marty, especially because we're a palliative care team, right? So we meet people at a very vulnerable time, more vulnerable than just your regular run-of-the-mill admission. These are people who have a serious illness. They're in a very vulnerable spot. And just to be able to feel relatable when you're already vulnerable is life-changing for patients and their families. Just to be able to see someone who understands your cultural nuances, right? Who understands why simple things like talking to the son over the daughter is important without it being demonstrative.
Mm.
So it's those kinds of things that make a difference to me in palliative care over any other medical discipline, because we are sitting in the spot between medicine and social dynamics for a lot of these patients in a very vulnerable way. And so it calls for us to be more sensitive to the patients and families in a way that probably other disciplines do not. Dr. Romlerfinger, I'm probably messing that up. I apologize in advance.
That was actually pretty close. Dr. Rommelfanger, Steve, for the purposes of this call, I'm one of Marty's colleagues, and I would echo what he said. I really, we've struggled because, like your earlier slide showed, it's very competitive trying to hire clinicians to work in palliative at this point, and to try to keep up with our patient load. When we've had, especially when we've had difficulty finding physicians to join the team, we're increasingly hiring APCs. I think I've observed the physician candidate pool might be a little bit more diverse, but especially in Wisconsin, it seems like the APC candidate pool is pretty uniform. So I think there have been a few challenges, even though we acknowledge the importance of having diversity on our team, just trying to counter that with the limited candidate pool we've got access to has been a challenge.
And that's Steve, that's the next question, is what are some of the barriers to implementing these health equity initiatives for our program? And that's what you're speaking to, is that the pool of people that we have to select from is not diverse. And, I think it goes back to training and educational level. I myself in medical school was in a class of 220, and there were 8 Black medical students. So all of us did not go into palliative care, right? So if you extrapolate that across the field, starting at medical school entry and admission and training, and go out, then you don't have a diverse population of candidates to choose from on our end when we're looking. And I think that's some of the level we have got to change it. I also think, speaking to what Marty said, having someone with a diverse background that can speak multiple language, I think sometimes we look at our visa residents and fellows kind of side-eye when we probably shouldn't, especially in palliative care. We should probably open arms and welcome them over, because they do have a different perspective and probably can speak to a patient population that we can't. Marty, is your hand is up, right?
Yeah, it is. So when I think of the different things that you can add that would bring diversity to a team, some of them you can see, some of them you can read in a CV, some of them you can't. And some of them it's really hard to ask about, or maybe you shouldn't be asking about in an interview. And so question kind of for you and Brittany, how do you, when you're hiring people, how do you sort of get at some of these diversity pieces? What do you ask? How do you ask? I don't know.
So I can tell you, for me, I do behavioral style interviewing. I don't do your bread and butter interviewing. I really ask behavioral question. I use the Studer behavior interview across the board, whether it's fellowship or candidates for employment. And it allows people to be more narrative in the interview. And I feel like narration gives me more insight into who the person is. So not what's your strength and weaknesses. People really don't know how to answer that question. But asking someone what you enjoy. What do you do to cope when you have a hard day? What you do? If you tell me a conflict in the past that you've had with an attending or someone above you, and what you did to, kind of talk to them about it. Like those behavioral type of questions allow people to tell you who they are in a narrative fashion. And then that helps me see if it's a good fit for what I need and who I have on my team, right? Because you kind of have to think about fit in a multi-factorial way. You don't want to bring someone onto the team that's going to wreck your internal team, but be good for the patient population, because then you're just in another battle. So that's what I tend to do, Marty. I I like the behavioral interview style more than anything else. Go ahead, Brittany.
Yeah, I was gonna say less about what you ask, but more about like infrastructure, the processes for the interviewing. So one thing that we've learned a lot about from DEI best practices is doing more of like a panel style interview, so that, you know, if it was just one person interviewing the candidate, they may say like, oh, that person wasn't the right fit, right? Like they may make this assumption that they wouldn't fit here. But, you know, we're really trying to go against that. Like why wouldn't they fit? What is that like blind spot or biases that's coming out of like them not fitting here? Because that actually may be what we're missing, right? Like they're not going to come in here and be cookie cutter or, you know, do business as usual. They may come in, shake things up, bring a different perspective that we might be missing. So I just wanted to acknowledge just like the style and being more flexible in how we've done it in the past can really help, I think, pick out candidates in a like a fresh perspective and be more inclusive than traditionally. So,
And I wholeheartedly agree with the panel, instead of a one-on-one. It gives you as a team something to discuss. Like Brittany's saying, after the interview, I feel like you have more meat to discuss from versus one-on-one. Go ahead, Rose.
Thank you. I think a lot about diversity and how we deal with family systems. I work in transplant palliative care, and so I'm part of the committee that decides who gets transplants, who doesn't. And I have found, because our very large committee is fairly homogenous, we don't understand a lot of family systems. And there are definitely kind of these microaggressions that you hear, like, well, there were 10 people in the room, I don't know who they were, you know, because that family doesn't look like yours. There's this assumption that it doesn't function and that would be a barrier, right?
Right.
So even when we have families that don't look like us, and back to kind of the interview process, right? Like just by looking at me, you don't necessarily know what my family looks like, right? But it would be really nice when we do have interviews with people who we want to work with to know a little bit more about that stuff, right? Like, or even whether that's socioeconomics from where you're from, whether that is gender identities, you know, diversity is huge. But we all have families. So that to me is something that I think is really, really important, especially in palliative care.
I wholeheartedly agree with you, Rose. I think, like I said, we're a unique discipline, and we serve a very unique population in a very vulnerable time, and we have to have a certain sensitivity to that goes beyond any other discipline. We are in the middle between medical and social. We're right there in that gap. So I remember there was a time when we were doing like politically correct training, whatever we call it in our field, right? Where you can't say this, you can't talk about politics, you can't talk about religion. You know, they have the pie and there's things you can't talk about. And I remember during that training one year raising my hand and saying, then how do you guys expect us to do our job?
Right.
Because those things are what have people make decisions. People make decisions based on their religion. People make decisions based on their political views. And we're asking people to tell us who you are so we can align who you are with the medical treatment. But you have given us this whole set that we can't talk about, which could be fundamentally who someone is, speaks to their intentionality, which is where their decisions are based out of. And so, of course, there was no response or no answer to it. It just, you know, we have to stay within the corporate realm. But I think it speaks to what you're saying, Rose. There is some unique things about what we do in palliative care that go beyond what's the typical or traditional way of interviewing. Because, you know, there's a whole set of things in interviews you can't ask, right? So it does become a barrier. And that, I think that speaks to our next question of what mechanism exists that allow you to collect and manage data that is relevant to this equity, to this health equity. which may include diagnosis, ethnicity, race, zip code served, because zip code speaks a lot about social economics, right, in primary language. I did a I did a needs assessment on the last program I was with, and a 10-mile radius around the hospital. And usually when I do my needs assessment, there is some area of low socioeconomic. It was not. For the first time in all my needs assessment, the 10-mile radius around this particular hospital was predominantly white males, middle-aged white males with the median income of 105K. So that spoke to the population we were serving, which was interesting because when I started there, I was told by the nurses that, oh, that's what they call a Buckhead Betty. And I had to realize that Buckhead Betty was the nurse's way of saying that's a snobby white woman who's used to getting what she wants, and she's gonna cause trouble because has a silver spoon, which then aligned to the people we served in that area. So it was very interesting. It's very interesting to me how we culturally in a hospital culture, what kind of name the type of population we're serving, or what kind of have these nicknames, as we call them in the South, about the people who we serve so that everyone knows who that patient is, right? But we never really look at it from a needs assessment and how to align that as our team. Go ahead, Marty.
I have practiced in some places that are pretty homogenous, not just the medical teams, but the population around. What do you think about diversity on teams like that?
So I think most programs should try to align with the community they serve as much as possible, but still have change agents embedded in the team. Because you're still going to serve people outside of the typical population. So even though that hospital had that particular demographic that was the most prevalent, we still serve people who were African American, who were Hispanic, who were Russian. And so we still have to have people on the team that can speak to that. I also think that you need to change agent to cause progression so that things don't stay homogenous. I think, like Brittany said, we need someone in the room that says, hey, but what about this? Or have we thought about this? We need someone in the room who's non-traditional, who doesn't think inside the box. Like, I'm the outside of the box thinker, and I am vocal, so I don't mind using my words. And so a lot of times I'm placed on a team to be the change agent or the person who speaks up and says, have we looked at it from this angle? Steve?
Hi, yes. So one of the things I was just reflecting on, this particular question is a little bit challenging because we're on Epic. We have one of the more advanced and expensive forms of Epic as our EHR. So we are starting to try to collect information regarding social determinants of health. I've found that it's hard for us in the hospital setting to really do anything to react to that. And I'm not sure if we're collecting anything further in our Epic, on our EHR we wouldn't glean from just doing a decent social history, talking to our patients. I've practiced in Milwaukee. I trained here as a resident. I've lived here for a long time. I know the neighborhoods. And during my family medicine training, it was drilled into me that I needed to know the communities. I needed to know where the patients lived and where they went and got their groceries, where they went to church, things like that. We did a field trip on a school bus to see the neighborhood. Clearly, it's not something we're doing with our physicians and APCs as we're hiring them into the organization for real jobs. So, so that's one thought. The other thing, and
maybe we should, Steve, now that you said that, go ahead, go to your next topic.
But another thing that I just thought of is that, although our clinicians may not be very diverse, we do have we do work with a fairly diverse spiritual care department at our hospitals. We don't have our own chaplain, but we do rely on them, and they participate in this Chalk Talk forum. I often will try to reach out to them if I need additional insight into things that I might be missing, not just, beyond just the patient's religion.
I think we do, now that you say that, Steve. I think it would be actually cool to incorporate field trips into hiring processes, so people know who they're serving and what they're getting into. I also think, as you were talking, I was thinking about home hospice, and how that exposure has always been lovely for me, because you do get to see people in their natural element. And I was also thinking about the fact that we have been pushing for years to move palliative care more towards the community setting, because of what you're saying. In the acute setting, we're limited to what we can do to bring the greatest impact to that psychosocial dynamic. So here are some tools that we wanted to share about how you can look at diversity, some things you can do to move towards a more diverse team. You can download the community assessment mapping activity on the CAPC website, which I helped put together. Woohoo, kudos. So it's pretty cool. It will allow you to look at your shameless plug, right, Marty? It will allow you to look at your community around your hospital where you want to, or whatever area you want to view. You can definitely review policy priorities for addressing disparity, which is also available on CAPC. We also have virtual office hours to discuss healthcare initiatives. You have to be a member of a CAPC member to get onto those virtual office hours. Of course, we have online discussion boards for equity champions. And then if you can review our CAPC Innovative Hub. In that Innovative Hub is the study that they did over a year to look at how Blacks are treated in palliative care and the things that are lacking in palliative care for the African American patient. So that's where it is, right, Brittany, in that hub? I'm not misspeaking, right?
Yeah, there should be a link to the webinar within that, but also the hub has some kind of like profiles. So it has about 6 or 7 currently health equity profiles about palliative care programs doing really creative things to ensure that their Black patient population is receiving more equitable care. So it's like information giving, but also inspirational too. So you can see like, I can try to replicate this, or, you know, it might just inspire you to do something within your environment. Yes.
And then this is our snapshot or picture of our community assessment in that community assessment hub. So you see you have different topics, if you've ever been on CAPC, different topics that you can do self-learning on, that you can download things, look at things. And there is a complete like stepwise thing you can follow to really map out your community. And I know we're right at the time with 1 minute to spare. This has been a very, very good topic. I pray and hope that you guys continue the dialogue within your teams and continue to speak to how to become more diverse as a team and really serve the population that you are currently caring for on your teams and in the community.
Dr. Newman, do you have time for one last question I see popped up in the chat, and then we'll conclude?
Oh, I didn't see it chat. Okay, yes.
Just did. Chandra, you wouldn't mind unmuting and asking, would you?
Hi, I don't know what my video would look like. Let me try to start. I'm kind of scooting. So I was just asking, as a solo provider that started a palliative care program in a very underserved area, predominantly Black, 83% in that area, what could be done? You know, even when new positions were posted, not many people coming fresh out of school were looking to come to that area, and not many people look to smaller communities, you know, and especially the ones that don't look like them. You know, there weren't very many young white nurses fresh out of school saying, let me go work in this particular area. So how do you draw people to communities that they wouldn't normally seek employment in?
It is so hard, Sandra. I mean, when I tell you, Brittany may have an answer from a national perspective, but I can tell you, I've had problems drawing staff, period, across the board, more or less trying to match it up. It's just, we're at such a major shortage in our field that we don't have a big pool to choose from. And I think a lot of times geographic matters. You know, even though I'm in Florida, I'm in North Florida, it's not a big draw to live here. So you have that compounded in there too. So I don't know how you can get it to match. And sometimes you can't get it to match. And sometimes you can't find the right fit. And you just have to kind of keep going or see if there's people within your team that'll move. But it's not an easy, what I've challenged you guys with is not easy. It's not an easy challenge or call.
Understood. Thank you.
It's easy to say, Chandra.
I know. That's why I form.
All right, folks. Dr. Newman, thank you today for your
You're
time,
welcome.
for being outspoken, and for being an agent of change. We appreciate it.
Thank you. Thank you, Marty. You guys have a good day.
All right. See you guys later. Bye.